All right, I'm the winner of 2 presentations. Thank you very much for accepting both abstracts. Now back to basic surgery. This was now very nice to have new devices, but now let's see how we get on with this. We're going to talk about fast-track anesthesia. It's an old concept, but when I set up the units in Namibia from 2009, we obviously had a lot of protocols and things to decide on, what we're going to do, how we're going to do them. I can tell you many stories. It was a very interesting time. So I don't have any disclosures. So, well, what can I say? I mean, 178 kilos, 178 centimeters, 178 kilos, BMI 55. Doing the operation is not a problem. Okay, getting this guy out of ICU is a problem. Okay, and getting him home is an even bigger problem. So we decided in 2009 already that we're going to adopt a fast-track cardiac anesthesia protocol. Because I firmly believe it's better to get these guys extubated as soon as possible and get them in a chair as soon as possible. So fast-track cardiac anesthesia emerged in the 1990s and since become quite a popular approach after heart surgery. Not all units do it, but it is a popular approach. The FTCA is a management protocol involving early extubation, early mobilization, and the whole heart team has to play along. You have to have an anesthetist who believes in it as well. By doing this, you decrease duration of ICU admissions, hospital stay, and hopefully complications. So the objective, if you make a decision to accept the protocol, you have to go back after a few years and have a look, did it work? So it was to review our protocol for all patients requiring cardiac surgery at our institution. So these are all comers, and it's sequential. So it's a retrospective, single institution, single surgeon review of experience with 835 consecutive patients who presented for surgery. And we collected data from 2009 to 2015. Diagnosis, time to extubation, length of ICU stay, hospital admission, complications, and mortality were investigated. So we had exclusion criteria from the beginning. If you bled post-op, we're not going to extubate you and see how you bleed to death. So more than 500 mils per hour, we decided not to extubate you and wait and take you back to find out where it's bleeding from. Severe hemodynamic instability, bilirubin more than 10 marks per kilo per minute, adrenaline more than 0.05 marks per kilo per minute, oral systolic blood pressure less than 100 on those inotropes. And people more than 80 years and people less than 2 years, we thought, well, let's see. So the basic anesthetic technique is quite important. That's why I've said your anesthetist has to play along. So we've got a standard pre-med midazolam 7.5 Nexium. We've got standard monitoring, TE for all patients, even for babies. We use fentanyl and midazolam as an induction, relaxation is rocuronium, and we use maintenance sevoflurane. I think the most important drug that we use in the protocol is dexmedetomidine, and we use that intraoperative and postoperative. And we use it up to 24 to 48 hours afterwards. This affords us to have patients who are lightly sedated, well analgesed, and not respiratory depressed. We use morphine, and we also use midazolam in the pump. So our results of 835 sequential patients that we operated, 470 were male, 360 were female, average age is about 50, and the range is about 1 year to 84 years. We performed a whole range of operations, coronary bypass surgery, plus or minus valves, valve surgery, valve repairs, valve replacements, congenital, and aortic aneurysms. We could implement this protocol on about 80% of patients. So 650 odd patients, we could physically do it, and it worked very well. So the patients were extubated about 3.5 hours post-op. I think we're probably still a bit scared to extubate on the table. A lot of units do that. And all patients were extubated when awake, analgesic, well analgesed, and hemodynamic stable in the ICU. So the average ICU stay is about 48 hours, 2 days. Mean hospital duration is about 6.5, 6 days. 16 patients that were extubated needed reintubation for various reasons: respiratory failure, hemodynamic instability, bleeding, etc., etc. 4 patients developed perioperative lung infection. Those are the fat oaks. Okay, they still get it. So it's not mutually exclusive, but I think it's less if you can extubate them early and mobilize them properly. Our 30-day mortality for all comers was 4.9%. So why did it fail? So we looked at that. 5.5% was due to bleeding. So the guy bled 400 mils an hour, not 500 mils, so we thought, let's take a chance. Hemodynamic instability at 40%, that was the biggest reason. So the patient was stable, we extubated him, 6 hours later he becomes unstable, he bled, or there's a reason, bad LV. So not awake enough. That's anesthetic speak for anaesthetist saying, oh, I rather want to go have a glass of wine now. I don't know, extubate the guy and wait. See if he fails. Age, more than 80 years, less than 2 years, about 16 patients. And then 13% other reasons. So in conclusion, I think the protocol in our setting, a third world setting, can be applied in a wide range of cardiac surgical interventions without undue risk. Incidence of reintubation, return to the intensive care unit, and perioperative pneumonia are low with this approach. Thanks.
Two questions.
The patients were extubated after 3-4 hours. Why were they kept for 48 hours in the ICU?
That's a very good question. My wife said if I get a difficult question, I'm saying look at Wikipedia. No, it's probably a function of monitoring the patient still, making sure he gets completely off inotropes. Not all patients that were extubated early were off inotropes. Some patients, a lot of patients might still be on inotropes. We initialize physiotherapy in the ICU. So we've got about 25% atrial fibrillation post-coronary artery surgery. So these are the main reasons why we tend to keep them for 2 days. Not often will I discharge a patient on day 1 post-open heart surgery. Probably a bit scared on my side as well.
What's the stabilization time?
About 6.5 days, 7 days, about a week. Yeah, so about a week. Yeah, so we get them. I tell the patients when they can climb stairs, they can go home, and most guys want to climb stairs. Yeah.
Can I just chip in here? We have very different circumstances, and we have the same in South Africa. You have step-down facilities. So if you say you have half a day ICU, it's actually not completely the truth, because you're sending the patients then to a semi-ICU, which we don't have. And also the staff quality is slightly different.
Yeah, our patients go from ICU to ward. So 1 to 1, 2 to 1, to 1 to 40. So that's why they must be safe before they go.
So it's logistics. Can you just elaborate?
It's probably logistics as well, but also we don't have intermediate facility. It's either or. Yeah.
Just elaborate a little bit about those 1.8% who had to be reintubated. What was the destination?
Most of it was for hemodynamic instability, and the other big group was COPD. Okay, we have a lot of patients who smoke, and COPD is a big risk to extubate early, but it's also a big risk to ventilate long. So we try to look at the middle road, and we try to extubate COPD patients early and get them out of bed early and get them physio early. But sometimes you fail. And I'm sure a lot of you guys have seen patients, you do your round at 10 o'clock at night and he sits in the bed like this, and then that patient you have to reintubate.
I'm sorry that apparently we have to finish at 6 o'clock. We're still, because they need the room. So I'm sorry, but we have the last presentation.
Thank you very much.